Hello and welcome to this third installment on the genitourinary history. I'm Dr. Joel Vaughan with you again. And as you can see by the way I've divided this up, this is a big, broad topic. And I really want to focus in on all of the aspects of it because it's a topic that people tend to, by nature, want to stay away from. And yet, as I'm constantly telling you guys, if we consider why we're doing all of this, that we want to take excellent care of human beings who are made by God, if God made them and cares for them, certainly they're very valuable, and we should do the same with excellence, with compassion. And, it can be difficult sometimes with these topics because, of course, some of these more difficult problems people suffer are somewhat of their own making. They may be not acceptable socially, particularly in this society where we're all living right now. So I want to really go through this in depth, in addition to the urinary history we've already done, which is a little less difficult, the breast history, which is a little bit more sensitive. Now we're going to move on to perhaps the most sensitive of all of these topics. And so let's go ahead and dive in and talk through things. So first of all, let's focus in on the gynecological history and then, some relevant symptoms and definitions and things you need to be aware of as you dive into getting a good history. Obviously, a big issue is menstruation. You want to be aware of what the normal menstrual cycle is. So obviously, a big thing to understand on the front end is the timing of the menstrual cycle. We start timing it as from the first day of one menstrual period to the first day of the next. And so the length of the cycle is the first day of one period to the first day of the next. And that's something you may have to define for your patients, just so they can give you an accurate count on how long their cycles are. They average about 28 days, about 1 month. But it can be anywhere from 22 to 35 days. If it's more than 35 days, that's pathological. Relatively, it's delayed. And then if it's less than 22 days, that's too quick, and that's pathological. May lead to a condition called menorrhagia. And you bleed typically anywhere between 3 and 6 days at the beginning of the period. And obviously, people can bleed longer. Again, excess bleeding, menorrhagia, can occur. And that bleeding, you want to quantify exactly, what it's like. So we can talk more about that in a minute. So that's, how you time the menstrual cycle and what to expect from people as they answer. Then there's, of course, abnormal uterine bleeding. I referenced that a little bit in terms of different time periods. But, people can get very heavy bleeding. That's quite common. And you want to quantify that because you can't, asking for quantity of blood. They say the average quantity is about 35 mLs. Well, that's tough. That's subjective when it comes to measuring it. So what can help you? Well, you can ask them how many pads or tampons they use, how often they change them, especially overnight. That'll give you an idea. Other symptoms that indicate heavy bleeding are things like flooding, where they soak through the protection they're wearing. If there are clots present, that signifies heavy bleeding. And obviously, if they have symptoms of anemia, the number one cause of anemia is iron deficiency anemia in women in their years where they're menstruating. So, other types of abnormal bleeding, people can bleed between periods, or they can have bleeding after sexual intercourse, so-called postcoital bleeding. And that will suggest cervical pathology, and you want to investigate that. That's one of the reasons why we do cervical smears and things like that. You can get amenorrhea. The periods are just absent. Now, obviously, some people have primary amenorrhea, which means that they haven't had any periods by the time they hit age 16. And there's a variety of things in that differential diagnosis, which we don't have to go into today. But just know that's abnormal. If you haven't started periods by age 16, that's not normal. It needs to be investigated. You can have secondary amenorrhea, which is no periods for longer than 3 months or 3 months or longer in somebody who's already previously menstruated. Obviously, the number one cause of that is pregnancy. But if they aren't pregnant, then you need to think about other possible causes as well. Again, we don't need to go into the differential diagnosis. The point is just to give you guys a framework for understanding the way these histories go. And then there's postmenopausal bleeding. This is really serious. I do really, really, really want you to remember this. If someone tells you they've been in menopause and they bleed, that signifies a pretty significant risk for cancer, endometrial cancer. About 10% of people with postmenopausal bleeding will have endometrial cancer, and that's a huge number for something as serious as cancer. So you want to always, always evaluate those ladies. So here's a list of gynecological terms. This is from Macleod. It's box 10.7 in that chapter on the genital urinary history. I'm sorry, the reproductive history and examination. So menarche is when the first period starts. So what age were they when they had their first menstrual period? In the West, that has gotten younger and younger, and nobody really knows why. It's a combination of factors, probably. Um, Menopause is the age you were when you had your last menstrual period. You can only tell what that is after you've had 1 year with no periods, but you wanted to define that for people. We talked a little bit already about heavy menstrual bleeding. Um, again, I use the term menorrhagia. Macleod is saying that term is out of favor. Okay, but you may hear people use it in medicine for sure. Intermenstrual bleeding, and that's that bleeding between periods we already talked about. We're thinking about hormonal pathology, endometrial pathology, cervical pathology. Postcoital bleeding, I already mentioned that. That's when you bleed after intercourse. Worry about the cervix. Postmenopausal bleeding. Okay, you've had a year of no periods, so you're in menopause and suddenly you bleed. Very serious, always investigate. Primary amenorrhea we define, secondary amenorrhea we define. Oligomenorrhea is you have your periods regularly, but they're long. The cycles are long, longer than 35 days. And so that's oligo, which means few, menorrhea. So few periods because the interval is longer. Okay, just so you know, when you're talking to other medical professionals, what terms to use and what they mean when they use these terms. Okay? All right. Another potential problem you may encounter when taking history for the gynecological area. This is from Macleod's box 10.8. So things can come out of the pelvis through the vaginal opening. So this is called prolapse. And any of those pelvic organs pretty much can prolapse out. So cysto refers to the bladder. So cystocele is when the anterior vaginal wall containing the bladder bulges outward. Rectocele, which is the posterior vaginal wall containing the rectum, prolapsing outward. Interocele, so this is obviously referring to the GI tract, intero. You get a bulge of the distal wall in the back posteriorly, and that's the far away wall. I think there's the very deep, and this prolapse contains small bowel and peritoneum. A urethrocoele, when you get prolapse of just the urethra into the vagina. Often, of course, it goes along with a cystocele, a bladder prolapse. There's also uterine prolapse. The uterus itself can prolapse outward through the vagina. Grade 1 is when it goes halfway to the hymen. Grade 2 is when it goes to the hymen. And then grade 3 is past the hymen but still staying within the vagina. And then this next term, proxidantia, is when you get proxidentia. Hard word for me to say, even though I speak English. It's an external prolapse of the uterus. This is what we call a grade 4 prolapse. Everything's out of the vagina. And then lastly, a vault prolapse, bulge of the roof of the vagina after a hysterectomy. So, all of this to say, so that's, somebody's had the uterus removed, but still the vagina itself is prolapsing outward. I don't really want you to know necessarily a definition for all of these terms, although they all do make sense. But again, it's just to give you an idea of when you go into the hospital and you read documentation, what people are talking about, and so you can join in clinical conversation knowing the right terminology. Okay, so let's get down to actually some of the biggest issues that present with the gynecological history, and pain is a big one. So pelvic pain is a huge and fairly complex and confusing set of issues. And so it's something you want to be aware of and think through. And that pain can take a variety of forms. And really, the history is what's going to give you the answer in the vast majority of cases about what is causing pain. So you want to be well aware of that. Okay, so let's move in and talk about some of these pelvic pain categories. Sorry, this isn't going to pan as smoothly. But let's look into the various types of history you're going to get and what are you going to call those things. So, if someone has ongoing pain during a period that is really most intense right before they menstruate, um, caused by uterine contraction, usually this type of pain is. But anyway, this timing of uh, during a period that's just the most intense before and during, that's going to be primary dysmenorrhea. So dysmenorrhea is going to refer to pain in and around the menstrual cycle. Um, if you have pain that gets worse and as the period goes on, this goes along more like with what's called endometriosis, which is a ectopic placement of endometrial tissue somewhere else other than the uterine lining, or chronic infection. That's secondary or progressive dysmenorrhea. So again, pain during the menstrual cycle or in and around the menstrual cycle is dysmenorrhea. Primary is you get pain and it gets most intense right before and during a period. That's more or less not pathological, but obviously it can be very life limiting, so you want to address that. But much more pathological is the secondary or progressive dysmenorrhea. Severe pain can be caused by ovarian torsion. You can mistake it for acute appendicitis sometimes, um, but it happens when an ovarian an ovarian cyst twists on its vascular pedicle. So that causes ischemia to that little bit of ovarian tissue, and the pain is really intense. Ischemic pain is typically very severe pain. Dyspareunia is pain. So this could be endometriosis again, could be related to pelvic adhesions that have had prior surgeries or infections in that area. Vaginismus is pain on penetration. So in other words, when the penis is inserted into the vaginal canal, you get involuntary contraction of the muscles of the pelvic floor, and it can make intercourse very difficult, if not impossible, and it's very painful for the female. Mittelschmerz is pain associated with follicle rupture during ovulation. This is typically pain that occurs in the middle of the cycle. So you can think of Mittel, reminding you of middle. Mittelschmerz is German. So in English, we think just the middle of the cycle, you get this Mittelschmerz pain with the follicle rupture. Okay, so just some different definitions. When you get a history of some of those things, that's how you put a medical term to it. So let's talk about just again, why is this difficult? Why is pelvic pain difficult? Let's focus in on some of these other factors here. So you look at just different things that can cause pain in that region. So you have uterine pain, you have ovarian pain, you have adhesions or pelvic infection, you have endometriosis. And these different things, when you look at the Socrates associated with them, have different characteristics. So uterine pain is going to be midline, whereas ovarian pain is going to be one side or the other typically. Adhesions or pelvic infection is going to give you more generalized lower abdominal pain. And endometriosis can be highly variable because that endometrial tissue that's been misplaced could be located in a variety of areas. The onset, uterine pain builds up right before the period. Ovarian pain, especially if it's that torsion we talked about, can be, or just the Mittelschmerz, can be sudden and it tends to come and go. Pelvic infection, again, builds up. It can be acute on top of chronic pain and just be a flare-up of existing pain. Endometriosis, again, it builds up, but it can also be sudden. Again, I don't have to read through this whole chart. It's from Macleod's. I would definitely suggest you guys go look at it and help yourselves distinguish amongst the various types of pain. But you see, as you collect the SOCRATES, you're going to be able to differentiate the most likely cause of pelvic pain. But you really have to get all of that history and get it pretty thoroughly to be able to categorize the pain and know how to proceed after the history. So just wanted to bring that before you guys. And really, that is, if I had to pick one thing in the chapter, I would really focus on this one. This is really important. Okay, so things to remember just in general. Uh, we already talked about the urinary system history, so don't forget about the possibility of urinary incontinence being associated with some of these issues in the pelvic area. Also, pelvic masses may not cause any symptoms at all. That may be the problem. The symptoms could look like constipation because it's blocking the colon. The symptoms could look like I've seen ovarian cancer that's very large in size put pressure on the bladder and lead to incontinence. So there's just a variety of things that can happen. So don't forget that some of these other issues may be lingering and lurking beneath the surface or around other things the patient's complaining of. And they may come up on screening, like the pelvic mass may come up when you're doing your pervaginal examination and bimanual exam. Okay, vaginal discharge is another really important one. I think probably most people, when they think of vaginal discharge, think of sexually transmitted infection, but it doesn't have to be that, of course. Most vaginal discharge is physiological, it's normal, and not associated with any problems. So normally, what do you get? You get this varying of the vaginal discharge over a cycle. Leading up to ovulation, it's abundant, it's clear, it's stretchy. And after you ovulate, after a female ovulates, the discharge gets less in quantity, it thickens up, and it doesn't tend to stretch because of that increased thickness. Um, that's the normal stuff. Now, of course, you can get discharge from infection, but not all of those are sexually transmitted infections. So amongst the non-sexual infections, this is not an exhaustive list. In other words, this is not everything, but these are a couple of the main things. One is the yeast infection, a Candida vaginalis infection. This tends to be white, thick, and chunky. We say curdy. So it's a pretty distinct discharge, and it's associated with vaginal itching most of the time. Um, and so when you get that history, even before you do the pervaginal examination and see evidence of Candida, you can be thinking in that direction if you hear the quality of the discharge. Bacterial vaginosis is a watery discharge, tends to have a fishy odor, sort of an ammonia odor, and the pH is high, more than 5. Normal vaginal pH is 4 to 5, so you go above 5, and you can check this with a pH paper on examination, you're thinking bacterial vaginosis. But in the history phase, you're going to get this watery discharge, fishy smelling history, and that'll make you think about bacterial vaginosis, an infection really caused by an overgrowth of things going out of balance in terms of the normal vaginal flora, vaginal bacteria. This one's caused by typically Gardnerella vaginalis is the bacteria there. But again, don't need to know that. Just know to get a history. If they say discharge, okay, well, tell me more about that. What color is it? Is it thick? Is it watery? What other symptoms do you have with it? Itching. Okay. So get that history. Okay. Lastly, of course, there is sexually transmitted infection where you could be having gonorrhea. You could be having chlamydia, or a variety of other things. Those are probably the main two we think about. But at any rate, in that case, it's more thick and purulent, the discharge. Especially with gonorrhea, chlamydia may be relatively asymptomatic, and that may cause problems in terms of diagnosing it and treating it and limiting its spread. But nonetheless, both are associated with discharge, and you'll get some other symptoms with it very often. You may have lesions like ulcerations of the vagina. You may have dysuria, so inflammation of the urethra, which is right there in that area as well. Abdominal pain. Or again, like I said, with chlamydia especially, you may have nothing to help guide you. So pay attention to the discharge, get a good history of the discharge, and then we're going to talk about the sexual history in a minute. What do you do when you think you might be dealing with sexually transmitted infection? All right, so the gynecological history. Putting all of these considerations together that I've already mentioned, and where do you focus in? How do you focus in? What tools do we have? So generally, You guys know all these things. Clarify the presenting complaint, get a good history, get that Socrates or Socrates history. Always, always, always get the patient's ideas, concerns, expectations. Some of these things are uncomfortable and they can be uncomfortable topics to bring up. So if the patient brings this up themselves, they say, I'm worried I might have a sexually transmitted infection. It takes a little bit of the pressure off you to bring it up, right? So let them guide you about what their concerns are. You may have to redirect them based on what you're finding out as you go through the process, but always hear their story from them. Get their ideas on it first before you dive in, sharing your own. Always, 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 I can't emphasize some of these things enough, consider pregnancy. If a female is menstruating, if she's in her reproductive years, always think about pregnancy as a cause of just about any symptom in the abdomen or pelvis. Um, Please don't get fooled by this. I know a lot of people are afraid to check, especially if a female's unmarried, say. That can be a big cultural problem here. It's not as much in the US or the West. Um, but boy, you can cause a lot of harm to the mother and to the baby if you neglect to find out whether a female is pregnant. And even if they say, there's no possible way I could be pregnant, I'm not saying you should call them a liar or that you should disbelieve everything people say, but boy, you have to know. If they are not having their period that day and they have an abdominal or pelvic complaint, you need to seriously consider getting a pregnancy test because you have to know. You have to know. If you're going to do an X-ray for somebody with abdominal pain, you don't want to irradiate a fetus in the womb, right? You don't want to give drugs that will cause malformations in a baby that's growing and developing inside its mother. So consider pregnancy. I'll stop talking about it. Ask about the last menstrual period. This goes along with considering pregnancy. If their last menstrual period is right now, you know they're not pregnant. You want to know not only when was it, but was it normal or not? Um, you want to ask about contraceptive use always, just to know. Even then, even if they're saying we're using contraception, that doesn't mean they're not pregnant. You still have to think about it. Ask about their fertility plans. Just know what they're thinking. Do they want children? Do they want children now or soon or not? And then ask about weight changes, other kind of just general lifestyle factors, what's going on to understand the patient's plight overall. Okay. Menstrual history. So this is really important. You're going to need to be able to do this. This is a chart from Macleod's box 10.11. I think I've told you guys that the charts and tables are a really good thing to pay attention to in Macleod's, and that's certainly true for this topic. So let's focus in on the menstrual history. Let me get this more centered up and zoomed in so we can look at it better. We already talked about some of these things. Menarche, you know what it is, but you want to make sure you get this history on everybody. So if it's a female who's menstruating, when did they start menstruating? If they're older, in their 50s, maybe it's not as important. Obviously, if they've had children, especially, maybe it's not important. But it still is something I tend to ask, just part of doing the same thing, doing everything the same way every time, so I don't forget anything. So you want to know, when did their menstruations start? You want to know their last menstrual period, as we just said. If it's late, you gotta exclude pregnancy. Have I said that already? Exclude pregnancy. If they're menopausal, again, if they haven't had a period for a year, ask them. How old were they when it stopped? How long is their bleeding? How many days do they bleed? And the amount of bleeding. You want to quantify how many days they bleed and then how much they bleed during those days. And if it's heavy, ask them, how many pads or tampons did you use? Do you have to get up at night to change the protection? How many times if you do have to get up? This kind of thing. You just want to quantify. Again, how heavy is the bleeding? Are the periods regular? This is really important, associated with a variety of different medical conditions. But you want to ask, how regular are they? And how long are they? So the normal is every 22 to 35 days. Around menopause, actually when periods first start, like after menarche, they can be more irregular, and then before menopause, they can get fairly irregular. Maybe an indication of those things going on. Is the bleeding erratic between periods or after intercourse? We've already talked about that possibility. That could indicate a problem you have to investigate. Ask about pain, especially can be common in early adolescence, so when they're just starting to have periods. again, painful periods aren't necessarily pathological or a problem. If you're just having uterine cramping, they can be um, difficult to deal with in the course of your life, and so you want to treat those. Um, but if it's older women and they haven't had painful periods before, that's something to investigate. And again, just make sure you ask them about pain. Um, they may not know whether it's normal or not, so ask about pain. So where are we so far? We established when their period started, when their last one was and wasn't normal. We asked about how long they bleed, how much they bleed during that time. Are the periods regular or not? Do they bleed any other time besides their menstrual period? And then pain. Always ask about pain. Certainly, pregnancies. Um, Boy, don't just ask how many pregnancies they've had. I mean, Dr. Ben may get into this in the obstetrics history, but ask about how many babies they've had, and then how many pregnancies they've had. Certainly in the West, people may not mention an abortion, or much more commonly, perhaps, is the idea that they may have um, a miscarriage or something like that. And if they've had a lot of them, that can indicate pathology you want to investigate. So ask about pregnancies and the outcomes of those pregnancies. Um, if there's infertility at issue, how long have they been trying? That's one thing different here. If people have been married for a year and they aren't pregnant yet, you guys know this in the culture, that people wonder what's wrong. Am I infertile? Well, waiting a year to get pregnant or having trouble trying to get pregnant rather for a year is not abnormal. It's not pathological necessarily. So you do want to know how long have you been trying, and then ask about other things about sexual function to help you sort of understand, what might be going on with that. But do inquire, is the patient trying to become pregnant? And if so, how long has she and her husband or partner been trying? Contraception. You want to know what she's using currently, if anything, and what she's used previously and how it worked. Maybe any side effects associated with it. Yeah, anyway, I'll get into some of those other things soon, but you can use hormonal contraception, intrauterine contraception. They can affect, of course, the bleeding patterns, especially if you're talking about hormones. So it can help you understand what's going on. And overall, about just life in general. Have they had any rapid or extreme weight loss? Uh, People with excessive exercise, like long distance runners, that sort of thing, may have irregular periods or oligoamenorrhea. In other words, they have very few periods. The cycle is longer than 35 days, or they aren't having periods. It tends to happen when their body weight drops a lot. Obviously, somebody who has uh, other body image problems, anorexia nervosa, things like that, they can, of course, have menstrual problems. Thyroid disease can lead to menstrual problems. So if they have a lot of weight gain and they're having a lot of intramenstrual bleeding, think about thyroid, that kind of stuff. So obesity causes excessive estrogen, and so it can affect the menstrual cycle and can cause infertility. Acne and hirsutism along with obesity can indicate an underlying hormonal disorder like polycystic ovarian syndrome or something like that. So again, I don't want you to know all the differential diagnoses of these things. Know what to ask. You have to know what to ask about the menstrual history. So that's all I really want to highlight here is how do you get a menstrual history? Let the patient tell you what's going on with their body because they're the expert in what's going on with them. But make sure you cover all those topics, okay? All right, sexual history. So this is a tough one, right? Or can be. It doesn't have to be. Um, so we have this box from Macleod about how do you take it, but I want to focus in on a couple of things first. So remember with this, you need to be at ease. If the patient senses you're nervous, they're going to be nervous. So this is why we practice these things, because you want to be at ease when you start talking about them. I think it's really important to be straightforward. I think a lot of us have a tendency to, what we say, beat around the bush when we're talking about these types of issues that we're uncomfortable discussing. So don't do that. Be straightforward. Ask simple, straightforward questions about information you need to know or want to know. And when you get responses from the patient, be non-judgmental. If they're telling you they're having sexual relationships with multiple partners simultaneously, you might be shocked. You might think that's wrong. Just listen. Just listen and affirm them with verbal and nonverbal cues. If someone's living an unhealthy lifestyle, of course you should address that. just don't address it immediately, and don't violate their trust by immediately judging them for the things they share with you. That can really make it difficult to do any of these histories. So build trust, mainly listen, mainly listen. If they tell you they're doing something you think is wrong, ask them, well, how do you feel about that? I'm listening to what you're saying, and I'm just wondering, how does your lifestyle make you feel? And they may say, I love my life. I'm not interested in changing it. Or they may say, I'm really depressed, or I hate what I do. I don't know why I do these things. Um, Again, be non-judgmental. Let them tell their story. And you can certainly address issues of pathology as you gain their trust. Maybe they ask for your opinion, ideally, or ask for your help, but be non-judgmental. Be at ease. Be straightforward. Be non-judgmental. One of the ways I find it easy to introduce these topics is to explain to the patient why I'm asking. I say, look, I care about you as a person. I believe God made you. I believe God cares for you. I believe you're extremely valuable. Therefore, I want to take really good care of you. So to do that, I have to ask you some questions that may be a little uncomfortable. Um, and then I proceed to ask these questions about the sexual history or other uncomfortable topics in other areas. I think it's important to make clear to them that, look, these are questions I ask every single patient who presents to me the way you're presenting to me. I'm not singling you out. I'm not saying you're a bad person, but I really need to know this information because I want to take good care of you, is really what they need to understand. Okay? So be at ease. It's tough. Take a deep breath and dive in. Be straightforward. Don't beat around the bush. Just ask them directly and simply what you want to know. Don't judge. Listen, listen, and don't judge. Um, Again, we hope to earn the right to be able to discuss these things further with them as we build trust, but don't judge immediately. Just listen and explain to them why you're asking to help you introduce these topics. All right, so how do you do it? What do you ask them? Oops, wrong direction. Let's go back. So, when you want to take a sexual history, I proceed this way. Are you currently in a relationship? They may say, yes, I'm married. And you may go, okay, breathe a sigh of relief. I don't have to dive into some of these other questions. At the same time, of course, them being married doesn't mean they're not involved in sexual relationships that are unhealthy or outside the bounds of marriage, sadly. Um, so, are you currently in a relationship? If you are in a relationship, how long have you been in a relationship? Um, and then you can ask the question, is your relationship a sexual one? Now, in the West, I think the assumption here would be, one, you wouldn't be in a relationship with a female or a male if you're the opposite sex unless you were married. And that's helpful in a lot of ways in the culture, prevents a lot of problems. But your assumption may be false. You need to ask. You don't know what's going on in people's personal lives all the time. Um, yeah, anyway, so you do want to know if they are in a relationship, is it a sexual one? In the West, maybe they're in a relationship and it's not. Maybe they're in a relationship and it is. These are easier topics to ask in the West at sometimes because we are more open, um, but still, it's difficult to talk about. But proceed this way. Are you in a relationship? How long have you been in this relationship? Is it a sexual relationship? And then the other question. So if you are in a sexual relationship, have you had any other sexual partners recently, in the last year we're talking about? And again, staying non-judgmental, don't assume that a male is in a relationship with a female, and don't assume that a female is in a relationship with a male. Um, Certainly in the West, that's an issue, but it's also an issue here. You got to consider that homosexuality could be what's going on. You want to identify that because there are risk factors for certain diseases. And again, not making assumptions, not being judgmental, but just asking things in a straightforward way, just to collect information so you can try to help them. Um, you want to get their current status, then also, when did you last have sexual intercourse with your partner or with someone else? In other words, if they're in a sexual relationship, okay, well, when did you last have sex? And if they're in a sexual relationship with more than one person, again, find out when the last time was. Did they use barrier contraception? Sometimes, always, or never. You want to know, are they protecting themselves from sexually transmitted infections? Were condoms used, say, to prevent the spread of HIV, gonorrhea, chlamydia, herpes. Again, condoms aren't perfect, but they're very, very effective. So you want to ask, did they protect themselves or not? If not, you got to worry more, right? Um, then a key question to ask them is, have you ever before had a sexually transmitted infection? Especially if you think they have one right now. Having one before is a major risk factor for having one right now. What was it? How was it treated? Did you complete the treatment? Were there any complications? This kind of thing is really, really important. That's why we care so much about these infections and getting good history. And are you concerned about any sexual issues? It's a good way to open the door to, are you satisfied with your sexual life? Are you having pain with intercourse? Are you infertile? All of these things to ask about. So you want to really take these questions to heart and use them. Again, use them in a straightforward manner, use them in a non-judgmental manner, because you're going to need to collect this history more often than you think. If you don't ever ask these questions, I guarantee you are missing a lot of problems. You are losing an opportunity to help many, many people if you do not ask these questions. It's certainly true in the US. I think the assumption here that it's not true here, it gets you in trouble for asking these things. That's why you have to really build a relationship with the patient. They have to know you love them and care for them. They have to know that you're doing your job by asking them these straightforward, non-judgmental, open-ended questions about their sexuality because you really want to help. But again, if you're not asking, you're losing the opportunity to help them. So, are you currently in a relationship? How long has that relationship been in effect? Is it a sexual relationship? Have you had any other sexual encounters in the prior 12 months outside of that relationship? How many of those were male? How many were female? That's a non-judgmental way to ask about homosexual sexual activity. And again, that carries risk for different things than heterosexual sexual activity. Not dramatically different, but definitely different. And you want to be aware of that so you can take the best care of them possible. When was the last intercourse with their partner or with anyone else? And did they protect themselves with barrier contraception? Sometimes, always, or never. If they say sometimes, it might as well be never. Even if they say always, I don't always necessarily believe them. They may be forgetting a time that they forgot, that kind of thing. But just again, ask them, take down the information in a non-judgmental way. Have you ever had a sexually transmitted infection? If they did, what was it? How was it treated? What was the outcome? And are you concerned about any sexual issues? Okay, so again, you might start this whole encounter by asking them when they say, I have vaginal discharge or urethral discharge in a male, ask them, okay, what do you think might be going on? And let them lead you in the direction of sexually transmitted infection and then go in and ask some of these questions. It opens the door a little easier if they're bringing it up by you letting them share their ideas, concerns, and expectations. Okay, that's enough on that, right? Other history considerations, particularly for a female gynecological history, ask about the past medical history, of course, in general, but then make sure you get answers as far as are they having cervical smears to screen for cervical cancer? Have they been normal or have they been abnormal? If they were abnormal, how is that followed up? How is that treated? Have they ever had sexually transmitted infections? We already talked about that. Have they had pregnancies? What were the outcomes of those pregnancies? We already mentioned most of those things. The drug history. So you want to know, are they taking any contraception or other hormonal medication like hormonal replacement therapy? If they're in menopause and having symptoms like hot flashes, maybe they take hormones to abate those. You want to know what they're taking. You want to know if they're planning on having a baby, are they taking drugs that need to be stopped before they get pregnant that might cause harm to the fetus? That kind of thing, really, really important. Their family history. So do they have a family history of cancer? Whenever you ask about family history about any topic, you do want to ask about cancer because obviously there are a number of cancers that are genetically, or the risk is genetically transmitted. That's certainly true when you look at ovarian cancer, breast cancer. So you want to ask about that. Diabetes can cause a variety of problems, maybe associated with polycystic ovarian syndrome. So you want to know if that runs in the family because if it does, that's an increased risk to your patient that they might develop those same problems. And then bleeding disorders. Sometimes heavy menstrual bleeding is the result of a bleeding disorder, and some of those are genetically determined risk. The risk is genetically determined and it comes to their family. And then social history, smoking, their occupation, their lifestyle. How do all of these things combine to affect their sexual health, their reproductive health? Smoking is bad for babies. It also makes fertility more difficult. Um, if they're working really, really, really hard, they may have to slacken up that work schedule when they become pregnant because that leads to a risk of complications with the pregnancy, that kind of thing. And just in general, their lifestyle. You have a good picture of their lifestyle as you get the sexual history, but um, certainly all sorts of other recreational drug use, illicit or illegal drug use, is bad for pregnancy, bad for people's health. So you want to be aware of all of these things. Yeah, and another thing with smoking, like when you look at cancers, their risk of certain cancers is increased. Their risk of certain cancers recurring is increased if they're smoking. So again, just get a good, thorough history hitting all the areas: the presenting complaint, the past medical history, the drug history, the family history, the social history, and just be aware of how those things bear on genital or reproductive health. Okay, so we've kind of focused on females, not really intentionally, and I really couldn't figure out a better way to divide this up. Obviously, a lot of the things we've talked about apply to males too when it comes to, say, the sexual history and things, but say the menstrual history does not, obviously. So let's just focus specifically on the males for a minute and then we'll wrap things up. So just general considerations. I think about breaking things down into structural issues and functional issues. And I think this is helpful in a lot of ways, but let's see how that works out. When you look at possible symptoms males could present with, say the penis and the urethra. So we think about all the structures of the male genital architecture. So they could have a problem with the penis. They may have phimosis, which is a narrowing of the foreskin that makes it difficult to retract, can lead to higher incidence of candida, things like that, yeast infections, that is, balanitis. But they can also have paraphimosis, which is a more serious condition where the foreskin gets retracted, but then you can't move it forward because it's too tight and you can't get it back over the glands. And that can actually lead to diminished blood flow to the glands, especially as the glands begins to swell. So paraphimosis is a much more serious condition needing relatively immediate urological intervention. Priapism is when men get an erection that lasts longer than 4 hours and won't come down. There's an association with sickle cell disease. So if you have someone from the Gulf with sickle cell disease and they're complaining of an erection that won't go down, they have priapism. This is a urological emergency. So you want to know what these things are so that when they complain to you about something, you know what category to put it in. These are structural problems that have to be dealt with. And there are others, of course. These are just some examples. Functional problems might be something along the lines of discharge. Well, if you have urethral discharge, say from a sexually transmitted infection or for any reason, you're going to have pain, you're going to have dysuria. It's going to be hard for you to go about your life. Okay, so it's a problem in the system's function. Abnormal things are coming out of the urethra. Ulcerations, maybe from herpes simplex virus, or obviously with syphilis, you can get the chancre, which is typically painless but very ugly looking. Um, Again, these are sort of structural, I guess, but again, they're going to come to you because things look abnormal. It's preventing them from doing what they need to do and want to do. Sexual dysfunction. So when it comes to these structures are supposed to work a certain way for emptying urine, for having sexual intercourse, and when they're not working right, men will come to you. If they don't come to you, or if they're kind of beating around the bush to these problems, you need to be able to more directly ask them about these problems using the sexual history we already talked about. But, are they having erectile dysfunction? Okay, and you want to inquire more about that. Okay, how long has that been going on? Is it a problem all the time or just some of the time? What are some other things going on in their lives? Um, do they have any evidence of other hormonal conditions? In other words, do they ever get an erection? If not, maybe it's a hormonal problem, this kind of thing. So they'll come to you for complaints in all of these areas. When it comes to the scrotum, you can think of lumps being the issue here. It could be a lump on the testicle, like testicular cancer. It could be a cyst of the epididymis. It could be an infection of the epididymis, like epididymitis, that needs to be treated, which would be a sexually transmitted infection in most young men and from E. coli in most older men. You could have a lump and pain from, say, a testicular torsion where the testicle gets twisted around and cuts off the blood supply and begins to swell and cause a lot of pain. So you want to be aware of these things. Like if they come to you with a lump, they're probably thinking cancer. Get their ICE, but make sure you get a good history of that and then a good examination of that. Pain, get a good Socrates pain history. Okay, the prostate, what are different problems that can affect that? Infection or inflammation of the prostate, like prostatitis. That's a functional problem, leads to pain, swelling of the prostate, difficulty with your urinary function, possibly. So that tends to be a sexually transmitted infection in men under the age of 35 and more like E. coli in men over the age of 35. Like epididymitis, hyperplasia, so abnormal growth of the prostate. Pretty much any elderly man is going to have this to some degree or another. The question is whether or not it affects his function. So this will present as a functional problem with urination, or perhaps you detect it on screening for prostate cancer, and of course then cancer. And you want to screen people appropriately with history and also by examination where it's appropriate. But again, this can present as a functional issue, not urinating well or something like that. And when you go to investigate and examine it, you find cancer, or maybe it doesn't present with a symptom at all. You're just screening them for cancer, and you find a nodule or a mass, or a very firm, hard, rocky prostate. So anyway, these are all issues to consider. I'm not trying to get you to memorize all of these things. That will come with time, but you do want to break things down into where can problems occur, what symptoms can occur, and what names do I put to those symptoms and problems as I get that information from history. So how do we put all this together? You guys know all this by now. You get the presenting complaint, and then you get all the details about it with Socrates or Socrates. You're going to define the problems they're having with function. In other words, make sure you inquire specifically about what they mean when they say certain things, or maybe ask, well, hey, you're saying you have this problem. Is it also associated with difficulty urinating or difficulty with your sexual function? That kind of thing. Get the patient's ideas, concerns, and expectations, because if they're willing to go there and bring up sensitive issues, it makes it easier for you to ask about those things. So let them say it in their own words, let them tell you what they're concerned about, and then you just take the ball and run with it. But always being ready, again, to introduce the idea of more sensitive topics in the history if they don't go there themselves. Just do it when it's necessary because you care for the patient. Past medical history, you want to know about urological procedures. If they've had a vasectomy, then that changes what you're thinking about their fertility and that sort of thing. If they've had a surgery for prostatic hyperplasia or prostate cancer, perhaps that explains why they're having urinary incontinence and erectile dysfunction. If they have an undescended testicle that's repaired as a child, maybe they have an increased risk of testicular cancer now because of that, even though it's been fixed and repaired. So you want to know their history in these areas. You want to know about sexually transmitted infections, when they occurred, how often they occurred, how they were treated, and what the results of that treatment were, and any complications that resulted. The drug history. Some drugs are for urological problems. So maybe they're taking an erectile dysfunction medication. Maybe they're taking a medication like an alpha blocker to make it easier to urinate because of their prostatic hyperplasia. But maybe they're on medications for their blood pressure that are causing erectile dysfunction. Maybe they're on an SSRI for depression or anxiety, and it's causing retrograde ejaculation or erectile dysfunction. So you want to ask not only about urological drugs, but also drugs that they're taking for other problems that are affecting their male genitourinary system. And sometimes they won't tell you about these things. You just need to ask. But I guarantee you, men who are having erectile dysfunction because of a blood pressure medicine or a depression medicine are not going to keep taking that in a lot of cases. So you need to be aware of these problems when they're occurring. Family history. If they have a family history of prostate cancer, especially at a young age, that's a risk factor for them having prostate cancer. You want to be aware of that and screen appropriately. Uh, and then, of course, a family history of structural problems like Peyronie's disease or an undescended testis. Those things run in families. Peyronie's disease is like we get fibrosis of um, some of the tissues of the penis, and it causes an abnormal curvature of the penis, which can affect sexual function. That can run in families, so you want to know if they have a risk for these sorts of things. And then the social history. Smoking is bad for you in all ways, as we've already said. And if it causes vascular problems, that may make it more difficult to have an erection. It may affect fertility. So you want to address that. It's a good thing. I've used it at times. I'm not ashamed to admit to get people motivated to quit smoking. If you tell men that it may be causing their erectile dysfunction or at least making it worse, that's a really good motivation to quit smoking, which I want them to do anyway. So I'm not ashamed to use that in my favor. Alcohol can cause erectile dysfunction or other problems, and recreational drugs as well. Another thing with alcohol and recreational drugs is that they impair your judgment. And so you may take risks you would not normally take and therefore end up with sexually transmitted infections or other problems related to that. So really do get a good, thorough history, even in some of these more sensitive areas that are difficult to ask about, not because you're prying into their personal lives, but because you're a doctor who wants to care for them in the best way possible. You want to know this information. And again, don't judge. You can counsel them about healthy behavior as you've listened and heard their whole story. You've probably earned the right to do that. So do address behaviors, but don't think of people as quote unquote bad people if they've had sexually transmitted infections or they're heavy alcohol users or anything like that. It's all of us have our own problems. None of us is perfect. It's up to God to judge, not us. We want to encourage people in the right direction and point out things that are harming them, but to do so in a loving and caring way. And so please, please, please do not look down on people. Even if it's just internally in your heart, in your mind, you're looking down on people, they will tell in your behavior and how you talk to them. And really just focus on loving and caring for people and letting that be the motivation for what you do. And that's hard. It's difficult because we ourselves are selfish human beings. But please, please, please approach the patient in a non-judgmental, loving, and caring way. It will really help them and it will help you as you try to care for them. All right, that's it. So as you can see, this is a huge topic. We've done the urinary system in one lecture, we've done history about breast tissue problems in another lecture, and now we've done the issues related to the other genital structures, the male genital area and the gynecologic history. So it is a lot, and it's super important. You guys need to master these skills, and so that's why we're introducing them now while you're young, so that you'll have lots of opportunity to practice. So if you have questions or concerns about anything, please email me. Otherwise, I'll see you guys in the lab where we will practice some of these things just to get you more comfortable using these skills so that you can use them in the right way when you get to see real patients in the very near future. All right, thank you very much.